All right, good afternoon, everyone. It's so great to have you on the call today. We just took a few minutes for people to introduce themselves. If you didn't get a chance to introduce yourself, please do put it in the chat, your name, where you're calling in from today, and what your role is in the facility where you're working. This is our introductory course to palliative care in humanitarian refugee camps in Kenya. And we're quite excited. We have several of our faculty members on this call. And we know with Project ECHO, this is an all teach, all learn atmosphere. So we will be learning from you as participants, and hopefully you'll get a chance to learn from the faculty today. If you do look at the screen, anyone who has a hashtag in front of their name is our faculty. So I'll just take a minute to introduce them, and then we'll get on to the topic of our session. If you can also rename yourself, if you do come up as your iPhone or your device name, it allows us to see who's on the call. And just please remain muted until we have time for discussion. So our first faculty is Ali Hami. Ali, do you want to say hi?
Good afternoon, everyone. I'm Ali Abdullah Khamis from the Dab Hagada refugee camp, one of the faculty members of palliative care. Hi to everyone.
Hey, Ali. Ali's been very committed to this program. He's been working in the camp for many years and is a really good resource. He currently works in the private sector, but had been working with IRC, International Rescue Committee, for a while. So it's great to have him on our call. And we have Sarah Renaud. You have time to unmute.
Hi. Sorry, I'm gonna just take myself off video here. Oh my gosh, I apologize. I'm actually
in the car.
There we go. Hi, I'm in the car. I'm heading back right now. It's nice to meet everybody. I'm Sarah. I am currently based in Nairobi. I'm a registered nurse from Canada, and I've been working with Erin here in Nairobi. She's included me in a lot of really wonderful projects going on, and I'm happy to be a part of the team here, learning from everybody. So also contributing some of the background that I have. So excited for today's session and nice to meet everybody.
Thanks, Sarah. And I think Vilma, would you like to introduce yourself? Vilma is one of our other faculty.
Yes, hi, how are you? Can you hear me?
Yep.
Hi, I am Vilma Olivos, and I've been near Toronto. I would say Toronto because it's not there, but I work for a community hospice, and I do visiting volunteers for people in the community and training and other things. And I'm really happy to be here and be able to be a part of this group. So thank you all for being here.
Thanks, Vilma. Vilma is one of our new faculty members. She's based out of Canada, but has a lot of experience in community-based hospice and palliative care work. So we're hoping that her and Sarah are actually going to be teaching next week, talking about communication, which is exciting. I see a few other people are introducing themselves in the chat. We have Dawood from MSF, Michael from IRC, Barbara from IRC. Great to have you guys all on the call. And I think we will get to our session for today. If you do have any technical issues, Shruti Vatsa is our technical support from Project ECHO India. So you can always reach out to her or just put any requests in the chat. So I'll just take the minute to introduce our speakers for today. We have Dr. Kayla. She is currently based in Canada and has extensive experience in palliative care for the adult population. I think she also does some pediatrics, but is much more focused on adults. So she'll be our expert for today, and has been previously has worked internationally in Uganda and a few other locations. And we have Dr. Marianne, who is calling in from Australia. She's going to be our pediatric expert for the session today. She's supported the Project ECHO training for the last several sessions, and we're really excited that she'll be here. Our topic for today is focusing on symptoms and end-of-life care within the adult and the pediatric population. So Dr. Kayla and Dr. Marianne are going to be co-teaching this session, and we're going to be running the case throughout the lecture. So hopefully that worked well for everyone today. And I'll hand it over to Kayla to start the session.
Thank you so much, Erin. Yeah, hi everybody. My name is Kayla Wolofsky. I'm a physician here in Toronto. I do primarily, actually only adult palliative care. I've spent some time in Uganda as well as Ethiopia, and I'm really excited to speak to you today. I don't know if Marianne wants to quickly say hello.
Hi, I'm in Perth in Western Australia. I'm a pediatric palliative care physician, and I've previously worked in West Africa, Romania, and in Cambodia. So yeah, and I've been involved with ECHO, as was mentioned, for a number of years, but mostly actually based in Australia and trying to teach to our rural and remote communities here.
So today we're here to speak to you about symptom management, primarily with patients who have advanced disease, and kind of also allude to how you do end-of-life care in both the adult and pediatric perspective. And as Erin said, we're going to work through the case. It's a fairly large topic. We'll have some key bullet points for you to take home, but it worked best to kind of have the case throughout the lecture. So if we could go to the first slide, Erin. So Marianne's and I goals are for you to really understand common symptoms that are related to advanced disease, chronic illness, end-of-life situations, and in both adults and pediatrics. As you see below, these are 4 very common symptoms that we manage in palliative care. Things like shortness of breath, nausea and vomiting, anxiety and agitation, and secretions. Next slide. So just as we look at this picture, can anybody think about, so many people think about cancer as a chronic illness and only associate that with palliative care. Are there any other chronic illnesses that you think palliative care could be applied to? Think about things related to the heart. So patients who have really bad heart failure, or patients who have really bad TB or lung infection, or even end-stage infectious disease. Exactly, end-stage renal disease, exactly. They're very symptomatic, and liver disease. And so the purpose of me telling you this is that I just want you to, the take-home message to be is that palliative care doesn't only have to be applied to patients with cancer. This can be applied to anybody who has a life-limiting illness and has very bad symptoms. And the goal is truly to improve their quality of life. Thanks, Erin. Next slide. I'd like you to meet Ahmed. We've got a 52-year-old gentleman who has pancreatic cancer. Unfortunately, it's very progressed with metastases to lung and liver, likely bone. He's quite unwell. He lives in Dadaab refugee camp with his wife, and he has 3 sons, quite young, ages 1, 3, and 12. He used to be a laborer, but unfortunately has not been able to work for several months due to worsening symptoms, including shortness of breath and nausea. He feels very unwell. You've gone to now visit him at home. What are the main symptoms here that we've identified? So I see shortness of breath and nausea, probably also fatigue. Yes, thanks, Barbara. What kind of questions? So when someone tells you that, yep, nausea and vomiting, excellent. So when you hear someone that's very short of breath and nausea, just what are some general questions you might have about his symptoms? Yep, duration. So how long has he been feeling unwell for? Perfect. Anything that makes his shortness of breath or nausea overall better, worse? Yeah, what's triggering it? How often is this happening? Does it get worse with activity? Wonderful. Absolutely associated pain. Yeah. I think one of the most important things about symptoms that I can just, if I were to just say and touch upon, is that it's really important to understand how long has it been going on for, what makes it better or worse, what are things that it's preventing them from doing, and that could be eating, interacting with their children. Okay, let's go to the next slide, Erin. So when you kind of get a further history of his symptoms, he also reports dyspnea, anxiety, and nausea. A lot of the time, at least in my practice, we rate things out of 10. And the reason being is it gives us a bench point. So when we ask him about his shortness of breath, he rates it 4 to 10 at rest, but it increases with activity. Things that make it better include bronchodilators, so things that open his airway, overall airflow, so open a window and having a fan by his bed, and if possible, oxygen. He does have very bad anxiety at 2 out of 10, except at night it increases to 6 out of 10. And unfortunately, with any meal, he seems to, with strong smells, he gets really nauseated. What are some of the next steps that you might want to do? So I think next steps, again, is to continue to take a history and do a physical exam. Those are always important because truly understanding the underlying cause of some of the symptoms is really helpful with how to manage it. And then next, we're going to do our best to try to manage his symptoms. And the best way forward is using non-pharmacologic measures. And then if those doesn't work, then we usually escalate to using medicines. Wonderful. Yep, as Erin said, check what medications he's taking. Perfect. Wonderful, everybody. Okay, next slide. So the first thing I wanted to talk about was dyspnea, and this means shortness of breath. And what I want you to understand is it's a subjective feeling. So there's some people who might be having an oxygen saturation of above 90% who just feel like they cannot breathe. So they can't catch their breath. They're like, ah, and you don't understand it. And so what I want to really tell you is that dyspnea is it's a feeling. It's feeling like they can't catch their breath, okay? It can obviously occur in people who have a low oxygen saturation. But to be honest with you, if someone says I feel shortness of breath, what their oxygen saturation looks like at this point won't change our management. Okay, thanks, Erin. Next slide. There's many causes of shortness of breath in palliative care. So like many, we see many cancer patients. So tumor involvement of the lung tissue or airways. So this could be a primary lung cancer, or it could be a metastases. Infection, like we talked about, pneumonia, COPD, heart failure, pulmonary embolism, weakness, ascites, so fluid in the abdomen, if they're anemic, or anxiety. So as you can see, the list of causes for dyspnea in a palliative care patient is quite long. Can anybody think of some non-pharmacological ways we can manage shortness of breath? So things that don't involve medicines. Yeah, positioning very important. So sitting them up. What are some other things that we actually also mentioned in the case study? Open the windows. Absolutely. So getting that airflow, because remember that it's a subjective feeling of shortness of breath. So if they have the feeling of air, it does actually really help. Good ventilation. Perfect. Wonderful. These are excellent suggestions. Okay. All right, why not? Fan and cold room, perfect, the fan. Exactly. So just again, that feeling of air on their face, it does a lot of wonderful things. Okay, next slide, Erin. So in terms of management, obviously do your very best to understand the underlying cause and see if you can treat the underlying cause. So if there's an infection, antibiotics, if it's COPD, getting their inhalers better. But if you can't fix the underlying cause, then this is a really good algorithm. In terms of education, I think, like I said, oxygen saturation is not correlated with shortness of breath. And our plan is to alter how the patient perceives their shortness of breath. So non-pharmacological things include cold facial stimulation, like someone else had mentioned, positioning, so sitting up, especially lying back, makes people feel very short of breath, a calm, quiet atmosphere, and if you have access to it, oxygen. In terms of pharmacology for adults, one of the first lines that we recommend is morphine. So whether you have liquid or PO, that works really well. Start on lower doses or the lowest dose possible. I recognize that there's some medications you have very limited access to in terms of a range of doses. Ideally, I start my patients around morphine 2.5 to 5 milligrams, and you can actually give this every 4 hours. If they have really bad secretions, so any kind of mucolytic, so anything to keep them from coughing would be really helpful. Codeine, which is sometimes found at various places, can also decrease the perceived shortness of breath. If you have access to steroids, so if this is related to a tumor or like COPD or very bad asthma, anything reactive, steroids can work quite well. And surprisingly, just having a lozenge in the mouth can be quite helpful. Now, as you can imagine, feeling short of breath can be very anxiety provoking. And so you can give something like lorazepam. I usually start at a lower dose, like 0.5 to 1 milligram. The other option you can use is oral diazepam. And the good thing about oral diazepam, especially in camps, is that if you don't have access to IV or sub-Q, this can be given orally or rectally. Thanks, Erin. Next slide. I'll pass over to Marianne.
Thanks, Kayla. So really for pediatrics, the background information would be very similar, but there is a different weighting in the cases that are likely to present in children. As you heard, the majority of patients that are coming through for palliative care and end-of-life care in adults have an underlying diagnosis of cancer, but that's not true in children. The majority of cases that are seen in children that need palliative care often relate to congenital disorders, for instance, cardiac abnormalities or neuromuscular disorders that have been inherited, or cystic fibrosis, or actually malnutrition and subsequent organ failure. So there is going to be cancer cases, but they are actually in the minority in children. And dyspnea in children with life-limiting conditions is relatively common. It can be intermittent and recoverable, or it can be reflecting of a true deterioration. The dyspnea would get worse in any child due to infection or anemia or pulmonary edema or muscle dysfunction. So when treating breathlessness in children, it's really important to try to have an understanding of what their illness or disease has been doing prior to their presentation and assessment. So assessing children, it's really important to get a very good history, and that is obviously often going to come from parents. Trying to get a history from the child is going to have to be done in language that the child understands and reflects their underlying age and development. And obviously age and development don't always go hand in hand. Clinical examination of a child is one of the biggest clues to whether there's breathlessness, and examining the child, you see an increased respiratory effort, and the child who's able to sit up already supporting themselves into an upright and sitting position, often leaning forward with their hands placed in between outstretched legs to just try and prop themselves upwards. And you'd see them using the accessory muscles of respiration, especially up in the neck, potentially with a nasal flare. Thanks. The next slide, please. So similarly for adults, to manage breathlessness, you try to get the child into a sitting position if they've not already adopted it, if there's oxygen available and if it's tolerated and if it's appropriate. So a lot of ifs. It might be helpful. Again, measuring the oxygen saturations is highly unlikely to be truly helpful. Many children do feel a little bit better when they're breathing in oxygen, but that may just be because of that sensation of increased flow of air across their face. Children who have got chronic respiratory disorders will often have become very used to a level of hypoxia or hypercapnia. So actually bringing in oxygen may in fact make them feel worse. So it's a necessity to get that really good background history of what's been going on. If there's a lot of secretions, then they can be suctioned carefully. And then, as Kayla said, correcting any reversible causes and using antibiotics or steroids or bronchodilators may well be helpful. If we're going to use opioids in children, then there isn't a fixed dose for children. We don't in children just give a certain dose. We do actually try to figure out what the dose is regarding to the child's size. So the dose of morphine that would be given by mouth to help with dyspnea, not for pain, this is a lower dose than would be used to manage pain, but for dyspnea it would be 0.1 milligrams per kilo given 4 hourly. If necessary, it can be given IV, and then the dose would be only 0.5 milligrams per kilo. Again, for anxiety, the anxiolytics, the benzos, are very useful. In children, one tends to use clonazepam if it's available, and the drops, they're very easy to place into any child's mouth because they're just placed, just buccally, just dripped into the mouth. Otherwise, we tend to use midazolam, but that can be given either intravenously or buccally as well. But obviously, if you've only got access to lorazepam or diazepam, those would be the agents to use. Just remembering to give a dose that's been calculated for the child's size and weight. Thank you.
So before we move on to the next case, we are covering a lot of material, but I want to make sure there's an opportunity for questions for each symptom, because I know we can forget them. Does anybody have any questions? And please feel free to put questions in the chat. Myself or Marianne or Erin are also monitoring. Shortness of breath, any questions?
Kayla, I know sometimes our family members have a lot of concerns about loved ones that are short of breath. Do you have any good suggestions on how the healthcare workers can support a caregiver?
Yeah, I think one thing is always like reassurance. And so I try to reassure people that, you know, we're there to support them. We're there to support their loved one. And that, you know, we do have tools in our tool belt to try to help with the symptoms. And I just let them know that it just takes some time to assess each medication. So that's one way I do it. And then also like spiritual care. So if they're spiritual, I see if they want any spiritual support, or if there's other community members that they want at bedside. But I've also read that it also it calms the diaphragm, so it decreases nerve stimulation. So I think there's various mechanisms, but we're not 100% sure exactly what they are. But I think it's quite multifactorial.
Yeah, that's true. As you made a reference to, it changes the perception of the dyspnea and the breathlessness. I think that's probably the biggest reason. It changes perception and decreases the patient's awareness of their breathlessness, and maybe improves the efficacy of breathing and exercise endurance. But yeah.
Wonderful. Any other questions before we move on? And of course, if you have any other questions, we'll keep an eye on the chat, okay? So to continue the case, we've got Ahmed, who's now slowly developing ascites. So he's getting fluid in his abdomen. And unfortunately, this is triggering significant nausea and vomiting. There's not like a clear trigger, so he just kind of gets this nausea and vomiting throughout the day. Unfortunately, he hasn't had a bowel movement. Luckily, there's no blood in his vomit, but unfortunately, he's not eating. When we think about nausea, are there any other key questions that you'd like to ask? Okay, maybe we'll keep moving just for time purposes, if that's okay, Erin. Yeah, exactly the kind of food he's eating. I'm sorry if I'm not leaving enough time to give you to type. Yeah, nausea. I don't know about all of you on the call, but feeling nauseous for me is one of the worst feelings in the world. And so it's a very important symptom that I feel that we need to address. So I'm glad we have the opportunity to talk about it today. Next slide. So one of the most important things I can tell you about nausea is it's kind of important to understand why it's occurring. And the reason I say that is you'll get a handout. I'm sorry if you didn't get it today, but we're going to give you a printout that each drug is very targeted. So the drugs that we're going to recommend hit a very specific receptor. And so you can use almost any anti-nausea medication to help with nausea. But if you truly understand the cause of the nausea, then you can pick the right drug to give that will probably have the most benefit. Again, recognizing that workup and medications can be limited. Of course, we give what we have, but if there's an opportunity to understand the mechanism, then I highly recommend it. What I just want to highlight here is I'd say there's about 4 different mechanisms. So there's the higher cortex, so that's kind of the brain, and that's where your vomiting centers in your medulla. And so this can be triggered by things like fear and pain, sights and smells, anticipation, and that's more higher cortex. Then in our vestibular apparatus, so within our inner ear, there's motion sickness and different surgeries, so anesthesias can kind of trigger this area. There's a chemoreceptor trigger zone in a different part of our brain, and this is like triggered by things like imbalance in potassium or sodium or your creatinine, various hormones, opioids, so unfortunately morphine and hydromorphone does trigger nausea in some people, chemotherapy, and various anesthetics. And in our stomach, which makes a lot of sense, there's also a lot of different receptors, primarily our vagus nerve. And this can be triggered by things like radiotherapy, surgery, chemotherapy, and of course, infectious disease. Next slide, Erin. Thank you. So, just like shortness of breath, the one thing I really want to kind of discuss is if you can correct the underlying cause, that's the best thing you can do. So whether it's an infection or managing their electrolytes, or if they have an obstruction, that will help the nausea. We need to adjust other medications and use any kind of adjuvant. I find when someone's really nauseous, you're almost better to schedule the medication than as needed, because unfortunately, when you get nauseous, it's really hard to catch up, and then you're unlikely to be able to take medications by mouth. It's important to select the route, and obviously that we might be limited where you are. And so if PO is the only option, then that's okay, but that's when it's really important to stay ahead of the nausea. If you think your patient's constipated, that can make nausea exponentially worse. And one of the most important things you can do is, again, environmental control. So really strong smells can trigger awful nausea. A cool damp cloth to the forehead, neck, and wrists. Next slide, Erin. So just like our dyspnea, let's go to non-pharmacological. So really important diet modifications. So adjusting for strong smells, strong taste, probably consistency also is very important. Addressing constipation. I would stop any kind of irritating medication like NSAIDs and try and complement an alternative medicine therapy. So ginger, peppermint, both work wonderful as a tea, lemon tea, or cardamom. Next slide, Erin. So as I won't spend much time on this slide, but again, it's really helpful if you can do mechanism based, and you'll get us a handout with the different medications and their mechanism. Next slide. So as mentioned, this is quite a busy slide, but again, you are going to get something, so don't be worried to try to memorize it. Depending on the mechanism is how you're going to manage. So the vomiting center is really good with like ondansetron or hyoscine or metoclopramide. Benzodiazepines like lorazepam are also really helpful. If it's a chemoreceptor trigger zone, there's a drug called haloperidol, which you'll use. And the stomach, actually, I find metoclopramide and ondansetron work quite well. And again, I want to reassure you, we'll give you a handout with all of this summarized. Next slide.
Kayla, there was just a question about constipation and nausea.
Oh, great question. So if you think about it, right, if you're really backed up, so think about a hose that has a kink in it. And so that kink is your constipation. If you're trying to feed more water into it, then it has nowhere to go. And so the stomach expands, and in general, you feel quite well. And because everything is backed up, you have the reflex to want to throw up. So it's a backed up system where the food has nowhere to go. So we are going to quickly touch upon some medications. Metoclopramide is a wonderful medication. It can be given in various routes, whether it's orally, subcutaneously, or through IV. The ways it works is it kind of kicks your gut into gear. So especially if you're constipated, this is a good medication because it kind of causes your gut to keep moving like this. The only thing you need to worry about is if there's an obstruction and you give it, if you're trying to force the gut to kind of move things along, you're causing a risk for it to balloon out. We do need to be careful for patients who have renal dysfunction, but overall metoclopramide is a very good drug, and I usually start at a dose of 10 milligrams. Another very good medication is domperidone. So 10 milligrams orally, and you can give it 3 times a day, and it's a maximum dose of 30 milligrams. Erin, I see your question, but I'll let someone else answer that. Next slide. One of my favorite medications for nausea is haloperidol. And again, this medication can be given orally or subcutaneously. And it's really good in general. It has a little bit of sedating effect. So if someone feels really unwell, they're a little bit less aware. It can treat the nausea. And I just find in general, it's a fairly good medication, especially when you're resource limited. So this is one of my other go-tos. Other medications, which I'm not sure if it would be available, are prochlormethazine. I can't even pronounce these words. Levotrimeprazine and olanzapine. These are kind of like second line when you don't know the cause of nausea. Next slide. Oh, wonderful. Okay, so I didn't speak about ondansetron. Sorry, Marianne, I might just touch upon this. So that's wonderful to know that metoclopramide and ondansetron are available. So wonderful. So metoclopramide, wonderful medication. Again, love it for especially if someone's constipated or you think the cause of nausea is like really gut related. I like ondansetron if they're getting chemotherapy or there's an electrolyte imbalance. So that's how I kind of choose between the two. So if I think the nausea is more in their head, it's smell associated, chemotherapy associated, that's when I use ondansetron. And if everything is more in the gut, I preferentially like metoclopramide. Wonderful. Okay, I'll let Marianne.
So this, I've just put this slide into Kayla's main presentation, really grouping the drugs that we would use in children in a similar way. So the place that the nausea or vomiting is coming from listed down on the left, and identifying again the most likely causes of nausea that are going to trigger onto those different places. For instance, the vomiting center would be as with pain or fear, or due to bowel obstruction or raised intracranial pressure. Then I've listed the different drugs that would be used in the different settings and the doses that, again, in children are worked out for their size. I think it's sort of fortuitous that the ones that I've put on the slide tend to be the ones that you've now identified are available. My particular favorites would be ondansetron, Maxilon, and lorazepam. And it's great to know that ondansetron is available because it is so very effective. Maxilon is a fantastic drug. It's fantastic really across all the ages, but one does need to be alert to the fact that Maxilon and prochlorperazine have a much higher incidence of causing dystonic reactions, especially in younger children. So there is an attempt to try and avoid using Maxilon, certainly in the under ones and probably in the under twos. So, it's a very good drug for most children, but one does need to be cautious in the infants. This slide really is just identifying the drugs that one would use in different settings and the different doses that you would use for children. Thanks, Kayla.
Erin, next slide. And so just like I mentioned before, really treating constipation is really important. So constipation occurs to dehydration, due to minimal movement. There's multiple causes. So I think at best, if you can ensure adequate hydration, as much of a high fiber diet as possible, things like prunes or just food with really high fiber content can really help the gut moving. And then if you aren't able to treat it kind of with non-pharmacological measures, medications like Senna or any kind of like irritant for the gut, so lactulose or polyethylene glycol can be quite helpful. What kind of constipating agents or anti-constipation agents do you have? If you don't mind me asking, if you can put in the chat. Okay, well, I'll keep an eye on the chat.
I know in other parts of Kenya, they use Bisacodyl. I don't know if they have that in the camp. I know the last one you said, the glycol one.
Polyethylene glycol.
Yeah, we don't really have that in Kenya,
okay.
But
that's okay.
But I think the other one.
If you have Senna, then that's a perfect drug. That's one of my favorite. I usually give like 1 tablet at night. It takes about 12 hours to work. So that's why I like giving it at night, is because like they'll sleep through the night and then usually in the morning they'll have a bowel movement. And I just kind of remind them that they're going to feel abdominal cramping. That's normal. I kind of give them that heads up so they don't get anxious. And so that way when you give Senna, they have a cramp in the morning and then that means they're going to have a bowel movement. I like lactulose as well. I think that's a really great medication. So Senna kind of works by irritating the stomach and forcing the muscles to kind of have a poop, whereas lactulose draws in fluid. And so therefore it kind of bulks it up and therefore they poop. But I think with lactulose, you have to remember you need to be adequately hydrated. Otherwise it doesn't work as well. Okay. And you have Bisacodyl. Wonderful. So you have some options. Great. All right, Erin, we're going to keep moving. Next slide.
So in children, sort of similar approach, you're trying to predict those that might get constipated in order to prevent it. One takes a slightly gentler approach to constipation in children, encouraging fluid and fiber intake if possible, and movement. One of the biggest causes of constipation is really lying around on the bed and not doing very much, and otherwise it's multiple medications can cause problems. So rationalizing the drugs that a child is already on. then really the treatment is, to be honest, the agents that happen to be available, but one would have to add in a level of caution using senna in children, because senna, as Kayla explained, causes basically cramps and bowel spasm in order to try and get the bowel moving, and that can be really very painful for children. So we tend to use lactulose or Caloxyl, but we do try to actually avoid the use of senna in kids. Suppositories is obviously a great way of relieving constipation for children, and that can be used in almost any age. So it's just a word of caution around the use of senna for kids, really.
Kayla,
Next slide.
Marianne, there's a few questions in the chat regarding some of these alternative uses of medications. I think this, there was a few questions here about haloperidol, back to the nausea, when we know,
All right.
and I know Dr. Barber also mentioned it, mostly they use it for mental health patients. Any thoughts on using Haldol? It's a
haloperidol. We don't use so much haloperidol in children, but it is a useful anti-nausea medication. I think, to be honest, one has to use what agents you've got available to you in order to relieve symptoms. What one's trying to do is identify the fact that using these meds in children needs to be taken into consideration. Obviously, a child can be anything from 1 day old through to 18, depending on your definition of a child. So we can't just rely on the fixed doses of agents that are used in adults. So the idea is really to identify that one needs to prescribe medications according to the weight.
And yeah, so with haloperidol, it's an anti-dopaminergic, so it works on the chemoreceptor trigger zone, and so it just seems to alleviate the nausea.
Yes, and Doris has made a very good comment. We would also recommend avoiding the use of suppositories or enemas in neutropenic patients. But I think probably if we put this talk, the scenario that we're talking about in this particular case really is around a dying patient and end of life. And to be quite honest, I think then the concerns around neutropenia start to have less relevance. But yes, on a day-by-day basis, we wouldn't use suppositories or enemas in a child who was having chemotherapy and was potentially neutropenic.
And Barbara, you're right. Polyethylene glycol is actually 100%. It's used to purge the bowel before colonoscopy. And it does that because it causes like clearing out of the bowels. So it's a more aggressive management, and that's kind of why we use it. Any other questions about nausea? I recognize we're going to get short on time, but I think the discussion's good. Okay, Erin, why don't we keep going? We'll try to get through as much as we can. So Ahmed is starting to feel very anxious over his disease progression. At nighttime, his family is noticing he's becoming more agitated and confused. And it's really distressing, not only to Ahmed, but also to his family as well. Any thoughts on how you differentiate between anxiety and delirium? It's just something to think about, and we can come back to that. I'll keep an eye on the chat, but they're very different. So why don't we go to the next slide? So anxiety. Next slide. So just big picture, delirium, if you remember, that's usually, it's medical terminology for waxing and waning of someone's like overall level of consciousness and how they're perceiving the world. So they're fluctuating. So sometimes they're really anxious, they're agitated, and other times they don't have any anxiety. They're not seeing things. So delirium, the most important thing is that it's fluctuating. It comes on later at night. Where anxiety is like more of a mental health, it's feeling like your heart's racing, this constant feeling like something bad is going to happen, or just anxiety over their death or their symptoms. So delirium is usually caused by something medical, whether it's like electrolytes or the cancer, whereas anxiety is part of the mental health spectrum. and it has to do with how you're feeling with your ongoing situation. So both are very common in someone who has chronic illness. And similarly, for both, you're going to do supportive counseling, complementary therapies, various medications, and using a little bit of both is the best. Next slide, Erin. So in terms of complementary therapies, so things like muscle relaxation can really help with anxiety. So massage, some people use guided imagery to get the focus off what their perceived anxiety is about. Hypnosis, meditation, various aromatherapy, so using aromas to calm someone's anxiety. Trying to avoid triggers, so things like caffeine that can cause your heart rate to go up. And also if they're not sleeping, that can also cause worsening anxiety. Next slide. When we think about chronic anxiety, so this is someone who's had generalized anxiety for the past few weeks and months. It's usually very specific about something. So whether it be their death or their chronic illness, it's a constant thought. So, oh my God, I'm going to die, or oh my goodness, something XYZ is going to happen. So it can be very specific. There's various medications that we can use, and these are SSRIs. It takes about 2 to 4 weeks. Overall, they're quite well tolerated, and they're only once a day dosing. The one thing is, if someone's very chronically end of life, these medications are not appropriate because it does take 2 to 4 weeks to work. Very common ones are things like paroxetine, citalopram, escitalopram, or sertraline. But again, these are really only appropriate if someone has a prognosis of longer than 6 weeks. Next slide. And so as you can imagine, having anxiety and constantly worrying is very stressful and very upsetting. And again, a lot of that anxiety can be passed on to the family as well. And so kind of supporting family members as they go through the anxiety with their patient is really important. Next slide. So like I mentioned, delirium and kind of confusion, it's an altered state of mind, and there's often like presence of confusion. It can be variable in when it comes on and comes off, and it can be quite severe, and sometimes it can be very benign. It's very complicated in patients with advanced illness. And it's really about, like I said, it's a generalized term for acute confusion, and it's not really a specific diagnosis. So again, what I mean by that is it can be caused by almost anything. And so therefore, it's not a specific diagnosis for an underlying cause. Next slide. There's different types of delirium, which is really interesting. There's hyperactive. So with these patients, they're very restless. They're very irritable. They're getting out of bed. They're quite agitated. They're just described as like not being themselves. And so family members are kind of very thrown off because they're like, who is this person? There's the other side, which is hypoactive. And so the patient's overly like, they're lying in bed. They're not really active. They're disengaged. They're not really interested. Most people kind of go through a mix, so they fluctuate between the hypo and the hyper. Next slide, Erin. In terms of how to manage this, again, I know we've mentioned quiet space, but for a lot of these symptoms, but honestly, that does really help. I think a reassuring atmosphere is really important. So for example, having like family nearby, and they're constantly orienting them. So for example, like time and place, just reassuring them that they're in a safe place. Delirium can often be caused by urinary retention, and that's often missed. So if you can help alleviate that, that's usually quite helpful. In terms of management, so haloperidol, a drug that you've mentioned a few times, is one of the best medications. I usually start at a dose of 0.5. And you can use that either subcutaneously or orally. So if you only have access to oral, then that's okay. I'm curious, and if someone could respond in the chat, do you have olanzapine? And the other medications you can use are things like lorazepam and diazepam. And again, diazepam is great because if you can't give something orally, you can give it rectally as well. Next slide. Unfortunately, Ahmed's continued to decline, and he's now minimally alert and not very responsive. His breathing has become irregular, and you can hear the pooling of secretions. The sound of the secretions is very distressing to the family. So at this point, he's starting to die. It's very common for patients and families to ask how much time they have left. This is the hardest question. And I find it as a physician, something I want to give the answer to the family because I do actually think it reassures them, or at least gives them a way to plan. And it's one of the hardest things to answer. And the way I kind of phrase it to family is I think about, tell me how they've looked and how fast they've declined. So if someone's been a slow decline over the past few months, then I tell them I think they have months. If it's been a quick decline over weeks or days, then I think the patient might have short amounts of time and maybe only days. One thing I will say is never be too specific. I work in intervals. So when someone asks me how much time they have, I ask them, how quickly have they declined in your eyes? And if they're like, oh, it's been quite rapid over the past few weeks, it's even getting faster in the past few days, then I usually say I worry that they might have days to weeks. So again, work in intervals. So hours to days, days to weeks, weeks to months, and then unknown. That's how I approach that question. How do we know if our patient's kind of nearing the end of the life? There's certain things that I look for that kind of signal to me that the patient's going to die very quickly. Obviously, if the patient's very weak and tired and isn't engaged, usually patients who are dying don't really take in food or fluids. Things I really look for are like respiratory changes. So you might have heard of Cheyne-Stokes breathing. So they might stop breathing and then all of a sudden they start breathing quite quickly. And overall decreased urine output. So really, I'm just looking for the breathing changes. So very slow breathing. I look at their skin to see if it's very cool, if it's mottled. And I'm just looking for overall decreased level of consciousness. So those are the things I look for. How do we manage and support a dying patient? I think this is so important. You know, we all try to live well, but it's important to die well as well. I think it's important, I know it seems straightforward, but to identify that the patient is dying. Oh, I think we went. Would you mind going back a slide, Erin? I think it's important to identify that the patient's dying. They're going to have different symptoms as they go through the dying process. So being with them, being with the family, and just continually assess, but also make sure that you're assessing their spiritual and psychological needs. I think it's important to anticipate likely problems. So we'll talk about one of them coming up called secretions. Some patients might also, again, be quite agitated. That's not uncommon. And so having these medications nearby is very important because as these symptoms come, they usually come on quite quickly. And so we want to be able to manage them quite promptly. Next slide. So secretions. There's different names for this, but really what you're hearing when we think of secretions in a dying patient, they're not conscious. Their face is kind of like their muscles in their face have relaxed. So their mouth is usually open and you can hear what sounds like fluid in the back of their throat. This is a really common symptom and it pretty much signals that someone only has hours to a few days left. It's really distressing to families. Families find it quite upsetting, but the truth is a lot of patients are not conscious or aware at this time. So it's not as distressing to the family. So a lot of the time we treat secretions for the family, but not so much for the patient. One of the most important things that you can do and the best thing you can do for a patient in this time is just position their head. So just prop it up, right? So you want to elongate their neck, rest it on a pillow, and that should help. And just if that doesn't work, just trying different positions and it should address the secretions. If that doesn't, and the secretions are very bothersome to the family, you can try atropine drops. And interestingly, you just put it under the tongue and it's just 1 to 3 drops under the tongue every 4 hours. If you have access to a scopolamine patch, that's another alternative medication. And if you're in hospital, then there is a wonderful medication called glycopyrrolate. But I think in the camps, the easiest medication is atropine eye drops under the tongue and just repositioning of the head. Next slide. Just some other considerations. Erin, I think this will be might just have to click through it. Yeah. I don't know that we have time to get through all of this. I want to make sure we have time for a few questions, but when someone's actively dying, if the family wants to feed them, I say that's okay, but I just let them know it's for comfort feeding, and that I do explain that there's a risk, especially if they're not able to chew their food. I think making sure that you do really good mouth care, so making sure their mouth is like moist and has like just as much hydration as possible. If you have access to artificial tears because they're not able to close their eyes. If you think a catheter would be helpful, that can also work. And just cool cloths to the forehead. And I think, again, just taking into consideration any spiritual or cultural considerations and last wishes. Next slide. Marianne, I think.
So, yeah, very, very little really to add to what Kayla has been explaining around the management of a dying adult, other than for children, obviously one is trying to also support the parents around the fact that the child is dying. And one of the best ways of doing that is predicting and managing the changes that the child is going to go through. So identifying to the parents what is likely to happen, explaining to them, educating them on how symptoms and changes can be managed, and engaging them into participating as part of being a carer during the dying phase provides reassurance and support to them just as much as one being present and helping and supporting the parents. Need to be mindful of support for the family includes supporting the siblings and the grandparents, who obviously in many situations have not expected to experience the loss of a grandchild before their own death. There's something wrong about a child dying, really, isn't there? So predicting the noisy and rattly breathing that might happen, and that's managed in a similar way as it is in adults. Restlessness and agitation, again, best managed with benzodiazepines. Bleeding, which is often a risk for patients who have got coagulation or coagulation problems or thrombocytopenia. Usually those would be associated with bone marrow failures or overwhelming malignancy, but predicting that that's going to happen and trying to ensure that there is access to dark cloths and towels in the room, so that should there be a catastrophic bleed near to the end of life, that the terrible scene that creates, the stark contrast that creates of blood against brightly colored white sheets, is just a phenomenal and is something that the parents will remember after the child's death. So if there's access to dark cloths that can be plunked onto the blood when it comes out, that's helpful, and explaining and predicting the circulatory and respiratory changes like Cheyne-Stokes breathing that Kayla mentioned. Next slide, please. And then just supporting the parents of a dying child means, being present, just staying with them and supporting and listening rather than talking or doing, listening with compassion and without judgment, and recognizing that parents grieve in many different ways. We must always put the child's needs first and foremost, but still maintain respect for the wishes of the family, the parents, and try, if we can, to meet the needs that they experience as they are participating in helping their child to have a good death, and recognizing and acknowledging that their emotions are valid, and that those emotions, doesn't matter what they are, cannot be squashed and shouldn't be squashed, and that's helpful and healthy as they then would be moving into the period of bereavement and appropriate grief. Thanks, Kayla.
Yeah, so, I think we knew where this case was going to end up. So Mr. Ahmed died peacefully at home, surrounded by his family. So just in summary, I just want to reiterate that symptoms really do affect our quality of life. And so trying to address them as best as possible is the best thing we can do for the patient, so they have a quality of life for however much time they have. It's really important to understand and treat the cause of these symptoms. Always attempt non-pharmacologic measures first, and many of them were very similar, which was like a calm environment with cool air, reassurance, and often reorientation. Obviously, escalate pharmacological therapy is required. It's important to consider route, whether it be oral, rectal, or subcutaneous if available. And the other thing I want to just say and really recognize is prognosis is very challenging. Next slide. Thank you so much for this honor to be able to speak to you all today. It was such a pleasure, and I'm sorry it wasn't more conversational, but there was quite a bit of material to get through today. But there will be some handouts that we'll leave with Erin.
Thank you so much, Dr. Kayla and Dr. Marianne. It's been, a really important session. I think we are trying to squeeze a lot of content into a few short weeks, but I think there's a lot of engagement. We may have time for maybe 2 questions. I know we've gone over a little bit, but if there are some questions, this is the time you can unmute or turn your video on if you have a particular patient that you're quite concerned about, even that you've been taking care of recently. Now is the time. Okay, so Barbara is saying for anxiety, is there room to start the SSRI in combination with the fast-acting anxiolytic, the benzodiazepine?
Absolutely. I think just the big picture, 100%, you can do both. They work in very different mechanisms. So it's not uncommon even here in Canada that we start something like sertraline or escitalopram, and in the meantime start lorazepam while it's taking into effect. I think the biggest thing is just that you don't see a benefit until 4 to 6 weeks. So if you think someone has short period of time to live, that's when I just don't usually start it. But absolutely, they have different mechanisms. You don't have to worry about interactions. So if you want to start something like citalopram or citalopram, in addition to lorazepam, that's absolutely safe.
Yeah, it seems like on this call, as we're getting to know the participants more, there is a good representation from the psychosocial group. There's some counselors, there's mental health providers. So yeah, I think it's really important in palliative care. We also really value multidisciplinary approach. So if there's someone on the team in the camp that is more confident in prescribing some of these medications rather than the clinical officer, I think asking them for their ideas or their perception on the situation would be really helpful. And if you have access to the medication and can use them, I think that would be really good. Does anyone, there was a question, any further questions from the group? Duncan, do you have any questions, or Dennis?
No questions. The session was so comprehensive. Thank you.
We do have a feedback form, so if you are able to take the next few minutes to fill that out, that would be helpful. We are going to continue next week, and next week we're going to talk about culturally sensitive communication. And I know that we are getting into some very cultural and ethical issues related to how we share prognosis with patients and how we talk about end of life and death. And it can be very different from one culture to the next. And I know some of our healthcare workers would be taking care of people in their same culture, so they may have a bit more understanding of what's appropriate. But I think that's also something that we do look forward to having discussions with you about in terms of how we engage. I know we talked about managing symptoms at end of life, but I think there's a lot that we as healthcare workers can do to support people and communicate with them. Sarah?
Okay. Dr. Marianne, I just wanted to add on really helped with care during palliative care have been to really develop a comprehensive background of the patient and family, like Dr. Kayla and Dr. Marianne were mentioning, really understanding the family and the patient, and even some of the dynamics between patient and family can be so helpful when you're caring for that patient. And it really speaks to the holistic approach of palliative care. And then I think the second thing that I've taken and I've learned throughout the years is to be really adaptable and flexible with your plan. That symptoms are ever changing, and to be flexible, to be able to respond when things change is so helpful and is so valuable, especially when end of life can sort of be shortening or people don't have many days and weeks. So trying to really strive for really good symptom management is wonderful. But yeah, thank you. More just a summary of that.
Thanks, Sarah. It was a little bit hard to hear you at the very beginning, but I think you were saying something in relation to really understanding the patient and their story and their background and the symptoms to be able to come up with a plan. And I think that's really, really important. I know that you all have different roles on the team. So of course, possibly a medical officer would take charge and make more of a treatment plan. But I think it's really important, as we have all different perspectives, that each person does really play a part in planning this treatment for a patient who's deteriorating. Barbara, I saw your hand was up. Dr. Barbara, I don't know if you have a final comment or question.
No, sorry, I raised it by mistake.
Okay, no problem. All right, well, thank
Thanks,
you
everyone.
everyone so much for being on the call. Thanks for being with us today. We've now talked a bit about an introduction to palliative care to understand what patients need. Palliative care, we've talked about pain last week, and now we've covered just some basics on symptom management for adults and children. So thank you so much for being here. If you can fill out the feedback form, that really helps us as we plan our session. And really looking forward to seeing you next week. Thanks, everyone. Thanks, Dr. Kayla. Thanks, Marianne. Thanks, Dr. Marianne.